Medical Service Company has made treating patients with sleep-disordered breathing a top priority. That is why we created MSC Sleep, a division with a commitment to investment in technology, clinicians, and processes, which creates a best-in-class experience for our patients and partners. At MSC Sleep, you can get the best choice for CPAP therapy. We expedite care to ensure patients receive their critical sleep therapy equipment fast. High-touch clinical care provides industry-leading compliance rates. Individualized communication for both the patient and the provider offer transparency from the prescription referral to PAP therapy setup. And finally, MSC has an internal team of over 30 sleep coaches making live outreach daily to assist patients throughout their journey on PAP therapy. On behalf of Medical Service Company and all of our partners for this event, we hope this forum provides information that will help you provide better care for sleep-disordered breathing patients across the entire nation. To learn more about the MSC Sleep Program, please visit us at medicalserviceco.com.
Good morning. I hope you enjoyed the first session. Our next session will be presented by Dr. Asim Roy. Dr. Roy is the medical director of the Ohio Sleep Medicine Institute in Columbus, Ohio. He is board certified in sleep medicine and neurology, and he works in close collaboration with healthcare providers to deliver continuous and coordinated sleep medicine care to adult and pediatric patients. Dr. Roy brings a thorough and thoughtful approach to patient care. Dr. Roy is the author of various articles, chapters, and books covering, among other topics, sleep and neurological disorders, restless leg syndrome, idiopathic hypersomnia, confusional arousals, along with sleepwalking, cataplexy, and REM sleep behavior disorder. Dr. Roy completed his neurology residency at Georgetown University as chief resident and his sleep and neurophysiology fellowship at the Cleveland Clinic Foundation. Dr. Roy is a big proponent of education, serving on the board of directors for the Committee on Accreditation for Polysomnographic Technologist Education. He is a member of the American Academy of Sleep Medicine, American Academy of Neurology, American Medical Association, and Columbus Medical Association. We are pleased to welcome Dr. Roy to our educational forum, and we appreciate his lecture and participation in our forum today. Today, Dr. Roy will be presenting a lecture on comprehensive approach to sleep apnea therapy. Dr. Roy will be taking questions from you after his lecture, so please enter your questions under the Engage tab, which can be found above the presentation screen. As a reminder, please be sure to complete and submit an evaluation after each lecture.
Hello, I'm Asim Roy. I'm medical director at Ohio Sleep Medicine Institute, also an assistant clinical professor at Northeast Ohio Medical University. And today I'm going to present a talk on comprehensive approach to sleep apnea. We all know snoring is a big problem. It's also a huge industry. There's so many over-the-counter gimmicks and things out there that people can go out to buy to try to stop their snoring. And many of our patients have attempted that prior to coming to see us typically. One of the things we do want to be mindful of, that snoring could be a sign, and often is a sign, of upper airway resistance, and can also potentially be a sign of sleep apnea as well. So it's important to educate patients on that concern. So a little background on obstructive sleep apnea. We know it's very prevalent. We estimate somewhere between 9 and 40% of the general population have an AHI of at least 5 or more. 6 to 17% of the general population probably has an AHI over 15. And if you look at above age 65 years of age, at least half or more of the adults will probably have sleep apnea. A recent publication from a few years ago by the World Health Organization estimated a prevalence rate of 1 billion people worldwide have sleep apnea. So we understand this is a major problem. We also know that it's associated with numerous dramatic physiologic challenges. And we know that, there's recurrent hypoxemia, potentially hypercapnia, wide swings in intrathoracic pressure, which can lead to some issues as well. And we know it's a chronic disorder. So we're going to go over some of the backgrounds related to therapies for sleep apnea. Obviously, we're all familiar with CPAP or BiPAP. We know there's some medical therapies I'm going to talk about, oral appliance or mandibular advancement devices, surgical management, some newer treatments with electrical stimulation and negative pressure. And then we're going to just summarize kind of what we feel is a comprehensive approach. So, a little background again, we know that apnea is a complete or majority of the airway is collapsed for at least 10 seconds or longer. And there's different types of collapse or stoppages in breathing. We know there's obstructive, there's central, and sometimes there's a mixed component where the patient has both an obstructive and a central component. What is a hypopnea? We know that's a partial airflow reduction of at least 50%. It is challenging to determine if a hypopnea is obstructive or central. So typically we all group most of our hypopneas under the obstructive category. However, some of them could be central. We also know that when normal breathing resumes, for most patients, there is an associated EEG arousal or disruption to their sleep. And then what we report out is an index, the apnea-hypopnea index, which is basically the number of these events per hour during sleep. What we consider normal is less than 5 events per hour. Mild is somewhere between 5 and 15. And moderate is somewhere between 15 and 30, and severe is considered greater than 30 events per hour. So in terms of testing, we've evolved over the years. Traditionally, we've always brought patients into the sleep lab. And what's been nice in the last few years is technology has gotten better and home sleep testing has kind of taken the forefront. And there's pros and cons to both of these approaches. Obviously, the pros of a home sleep study is the ease of use. It's at home. It's a much more natural environment in their own bed often. Significantly less sensors. We've gotten to the point where there may be only one sensor on the finger. And cost. Cost tends to be a little bit less. However, there is some marginal cost reduction in in-lab testing as well. So the cost factor may not be the same. The biggest negatives from our perspective is there is a significant false negative rate, especially in the milder cases of sleep apnea. So, and then the other thing is we've not standardized the equipment. So there's so many home sleep testing equipment out there. And which one do you use? How do we compare them? Are they apples to apples? So I think that becomes a challenge as well. And again, in mild sleep apnea or upper airway resistance, there are potentially ways to figure that out with home testing, but many times it can look inconclusive and then you're kind of left in the dark. And so some of those patients or many of those patients may end up in the sleep lab at that point. A classic in-lab PSG would look like this. You guys are probably familiar with most of this. What we're demonstrating here is an obstructive event. Here is a majority of the airflow is reduced. There's still respiratory effort. Both the abdominal and chest walls are still moving. And there's a dip in the oxygen and an arousal at the end of the apnea. So we would count this as one event and you require 5 or more per hour before we say this is pathologic. Now we know upper airway resistance might still be pathologic, causing symptoms, and they don't necessarily have to have the 5 events per hour or more. Again, just reiterating what we just talked about. Here is a demonstration of a hypopnea, and you can see the difference here. It's a partial stoppage in the airflow. There's still an associated drop in oxygen, and there is an EEG arousal that occurs at the end here. What is upper airway resistance? Typically, we deem this less than an AHI of 5. Some people argue an AHI of less than 10 should still be in that upper airway resistance syndrome category. These are inspiratory related arousals, typically associated with a snore, but not always, but it's all on inspiratory phase of the respiratory cycle where the arousal occurs. We know these patients often complain of fatigue, daytime sleepiness. Some of them may present with insomnia. They have trouble not only getting to sleep, but staying asleep because there are these disruptions during the night. And typically their oxygen levels are normal. So using a pulse ox alone, and again, sometimes often with an HST, is not a helpful tool to determine if they have upper airway resistance syndrome. So here's a nice picture of upper airway resistance. What you can see is this snore-related arousal. What we also see is this crescendo effect on the snoring, which is not always present, but it's nice to see. And on the end of inspiration, there's this basically a snore arousal that occurs. And this can happen 5, 10, 15, 20 times an hour or more, and you can result in this symptomatology that's similar to sleep apnea, where patients are tired or sleepy. Again, classic obstructive sleep apnea picture here is the retrolingual region, retropalate are wide open on the left here. And on the right, you see this negative pressure collapse that requires some sort of effort to open that airway up. And it's usually behind the tongue or behind the soft palate, where the majority of obstruction occurs. There are other areas of the airway that can be involved as well. So what are some of the symptoms? Probably one of the most common is excessive daytime sleepiness. And not always patients perceive this. They may not realize because it's come on so gradually. And again, it typically is secondary from increased fragmentation of sleep, or could be directly tied to the intermittent hypoxemia as well. We know snoring, again, not always present, but typically present, but you cannot rely on snoring alone. Other common symptoms are morning headaches, dry mouth, night sweats. Obviously, if someone's gasping or choking out of sleep, it's pretty obvious. Restless sleep, irritability, memory issues, non-refreshing sleep, reflux has been linked with sleep apnea as well. And then there's a subgroup of patients that are what we call asymptomatic. And the group we tend to see that are typically the cardiovascular patients, the ones with atrial fibrillation especially, are often asymptomatic for whatever reason. We don't understand fully. So that's a challenging group of patients to identify. And then also from a treatment perspective, may not perceive a difference with therapy. What other things can impact from daytime sleepiness? We know mood can be affected, behavioral problems, neurocognitive issues, performance issues, both at work and school, and then just other disruptions, just relationships, family members get frustrated with someone who's just not functioning at 100%. What are the other things we know that result in some of the damage related to sleep apnea is autonomic dysfunction. And we know from intermittent hypoxemia, this lack of oxygen, intermittent sleep fragmentation increases sympathetic tone. And this is a disruption of the parasympathetic system. So think of your autonomic system, the fight or flight component versus the background steady, which is the parasympathetic. The fight or flight system is getting activated every time a hypopnea or an apnea or an arousal is occurring. And so that's happening over and over and over all night long. What's going to happen? The body's going to be on this heightened alert, basically. And that's what we believe ties to a lot of the dysfunction that occurs tied to sleep apnea, most commonly linked to high blood pressure, is probably the most well studied in terms of impact of this sympathetic drive. What else has been, we know that at least 40 to 6% of sleep apnea patients have hypertension. We know if patients are on 3 drugs or more for their hypertension, it's almost a 90% pre-test probability that they have sleep apnea. So if you take everyone with hypertension, it's at least 40 to 60%. And if they are on more than three or more drugs to treat it, it's probably more than 90% likelihood they have sleep apnea. Can you reverse that? Many times we cannot, sometimes we can. The idea is the earlier we get to this disease, the more likely we can maybe alter some of the courses of these comorbid conditions. We know that sleep apnea is an independent risk factor for developing hypertension. This is all based on a prospective study, the Wisconsin Sleep Cohort Study, which is a huge ongoing study, and the Sleep Heart Health Study retrospectively noted that as well. We know MI is associated with it, cardiac arrhythmias. If you look at atrial fibrillation patients, 2 out of 3 patients with atrial fib will have sleep apnea. And the American Heart Association just came out with recent guidelines that all patients with atrial fibrillation and congestive heart failure need to be tested for sleep apnea independent of their symptoms. That's a pretty big statement. We know patients with stroke and TIA have a higher pre-test and post-test probability of sleep apnea. It's estimated somewhere between 60 and 70% of patients who've had a stroke or a TIA, which is not causing permanent damage to the brain, have sleep apnea as a potential underlying cause. We know diabetes, if you take all diabetics, at least 1 out of 2, so 50% of patients of diabetes have been shown to have sleep apnea and can impact their AM blood sugar, potentially impact their A1C levels. We know erectile dysfunction is one of the early signs in men that they might have sleep apnea. So it's important to be mindful that it can even occur before hypertension sets in. So if there's any signs of ED, important to think about screening for sleep apnea. Again, about half of the male population with sleep apnea present with ED. What are some of the predisposing factors? Again, we know obesity, but the challenge with obesity, using that as one of our leading, many patients perceive that if you're not obese, you can't have it. And we know that's not true. And so it's important to understand the upper airway anatomy. Do they have a reset lower jaw? Do they have large tonsils, large adenoids, especially in children? We see that hypothyroidism puts them at risk, family history. It's all about neuromuscular control. How well is their tone in their upper airway muscles? We know in women, postmenopausal women are at higher risk, equal to men having sleep apnea. So it's important to just kind of take that whole picture. And so in terms of treatment, we know the gold standard, it's been CPAP, which was invented in the early 1981 and has been the mainstay of therapy. But there are other therapies, and it's important to understand some patients, CPAP's just not going to work for them. How do we figure out who it works for, who it doesn't? We're not quite there yet in terms of going straight to the right treatment. So often these patients go through CPAP first, but struggle or can't tolerate it despite very good effort. And we know, hey, we need to be able to offer them other solutions, not ignore this disease, which has been the case for many years. Many patients just perceive if the CPAP's not going to work, I have nothing else to do. But really, we need to educate them. There's other solutions out there if this is not going to be their best choice for them. So very familiar, I know you all are, with CPAP. I don't want to spend too much time. We know masks have evolved over the years. The machines have evolved over the years, and they've gotten much better, quieter, easier to travel with, less obtrusive. So our success rate is significantly better than it was 10 years ago. But important to understand that it's not for everyone still. Traditionally, we know we used to bring patients in for a titration study. However, we know auto-adjusting CPAP, auto-PAP, has shown to be very efficacious. It tends to work in 50 to 60% of patients. There's still about 30 or 40% of these patients that still need in-lab titration, maybe because they need a BiPAP, maybe they have complex sleep apnea and they're going to need an ASV. So not everyone in auto-PAP is going to work for, but the bulk of patients should start on auto-PAP and do well with auto-PAP. Again, moderate to severe OSA, CPAP should be the gold standard. Here's a great example of someone with very severe sleep apnea, a little better on their side. They convert to some hypopneas here in the middle, but overall you can see still very severe. Here's a great titration. We wish all titrations look like this. And you can see the apneas are pretty resolved almost immediately. They probably are titrating to snoring or some other subtle features that we can't tell on the histogram here. Again, what do we know from CPAP? This is 40 years of data that we're looking at. We know it improves daytime sleepiness. Again, there's 30% of patients that will have residual hypersomnia despite effective CPAP therapy. So it's important to understand that not all patients will reverse their sleepiness. We know it eliminates hypoxemia. A majority of these patients, improves high blood pressure, reduces sympathetic activity. We know it helps with blood viscosity, which is one of the leading causes of stroke or MI in patients with sleep apnea. They have abnormal platelet and blood clotting factors, normalization of morning fibrinogen levels, again, all tied to the platelet aggregation and the likelihood of causing a stroke or MI. And so we know CPAP can reverse some of these changes. Excuse me. What are some of the reasons for CPAP failure? This is a common concern of our patients. You know, I've been told, oh, I tried CPAP and I failed, and you kind of want to dive deeper into why did they fail? Maybe they weren't titrated properly. Maybe the auto-PAP was not the right tool for them. So it's important to try to dive into that. Was pressure a problem? Education, I think it's really important to understand, hey, you're stopping breathing 15, 20 times an hour. What does that mean to the patient? Many patients don't understand what that means. I often will relate smoking as a potential correlate. So if you are at about 15 times an hour, the Sleep Wisconsin cohort study and the Sleep Heart Health study both showed it's almost on par or equivalent to smoking a pack of cigarettes a day. And sometimes that helps the patient relate to what these numbers mean to them. Humidification is a common issue. Too much, too little. Some patients like cold air. They don't want that warm air. Others need more warm air because of their sinuses or allergy issues. So it's important to dive deep into that. Were they given the wrong mask or not tried on different masks? Is claustrophobia an issue? Should we try to desensitize them? So there's a lot of reasons. And again, where they tried it 30 years ago, we know CPAP's better today. The masks are better. So you can't use that 30-year-old example of failure and tell them, hey, today, yeah, we should skip CPAP. Often revisiting it is important in that patient. And then I think follow-up is an important one. We need to be able to see them within a few weeks of starting treatment, making sure now with remote wireless downloads, we can track their data much more closely and engage them quicker than we could have before. If you throw them a CPAP and never see them again, this chance of success drops significantly. Again, a common motto, good night and good luck. Here's a patient who came to us, this is a few years ago, was told that he was not tolerating CPAP, and this is how he was wearing his mask. Obviously a simple fix there. It's not always that easy or obvious or that blatant, but again, that has happened out there. So what are some of the medical therapies for sleep apnea? So some guidelines were published about 15 years ago. These guidelines are probably going to change in the next few years because there's some new treatments that are showing some promise. Pretty much the medical options are weight reduction, bariatric surgery, or medical management of weight, pharmacologic agents, and since the early 80s, there's some data using protriptyline, which is something we use in our clinic, has shown to help with snoring and mild sleep apnea and upper airway resistance. Some recent studies out of Harvard show atomoxetine, which is Strattera, a commonly used drug for ADD or ADHD, and oxybutynin, which is an antimuscarinic medication used for overactive bladder. When combined together at bedtime, is showing significant promise for moderate to severe sleep apnea. So some patients may respond to this drug therapy. Other things that have been attempted, modafinil, antidepressants, estrogen, again, they're controversial, haven't shown full benefit. So it's important to understand right now it's still limited, but there's some promising data with some new therapies. Positional therapy, again, some patients purely have apnea on their back and on their side, they're pretty normal. Maybe positional therapy can be beneficial. Supplemental oxygen can work. It's again challenging to get oxygen covered for some of these patients. It's not recommended first line, but again, if they're not tolerating anything else, it definitely can help reduce the burden of the disease. It's almost better than nothing kind of mindset. And then nasal issues. So it's important to get an ear, nose, and throat doctor, an allergist involved. If they're having a lot of nasal congestion or deviated septum, may not improve their apnea overall, but may help them tolerate whatever treatment, maybe help tolerate the CPAP as well. Again, bariatric surgery, especially in patients that can have huge benefits just from an overall metabolic standpoint. And we know that many of these patients, at least about 60% will have resolution of their sleep apnea. About 40% have some mild residual or some degree of residual apnea that needs to still be addressed. So it's important to educate patients. Just weight loss alone may not cure them, but for many of them, it can be a cure potentially. And typically, the younger they are, the more likely it's primarily weight related. But again, it's all about their anatomy and their upper airway as well. What are some of the concerns? We're just not great studies to date with control groups or randomized design. We know the occurrence of OSA even without regaining weight has been shown. And again, up to 10% of patients have post-surgical complications from the surgery. So it's not a low-risk surgery, so it's important to be mindful of that. But again, a lot of these patients have exhausted weight loss measure, other ways to try to achieve some weight loss. In terms of pharmacotherapy, this is something we just mentioned earlier. Protriptyline is a tricyclic antidepressant. It's been around since the 70s. What's different, classically, if you think of TCAs or tricyclic antidepressants, they tend to be sedating for many of them. This one is alerting. So if given at bedtime, though, it may not keep them awake, but improve upper airway tone. And that's primarily thought to be driven by the norepinephrine reuptake inhibition. We know that it's metabolized to nortriptyline, which is not sedating either. In terms of protriptyline, back in 2006, it's not recommended as a primary treatment, but there is some moderate degree of clinical certainty that it can be considered. We do know there's data showing that it does improve snoring. The main side effect profile may limit its utility because of dry mouth, most commonly, the anticholinergic side effects that we sometimes see with this class of medicine. Again, dry mouth being the most common, but you can see there's a few other things that might be possible. This is the data from Harvard's group, Dr. Wellman's group, that showed 80 milligrams of atomoxetine, which is a norepinephrine targeted therapy, 5 milligrams of oxybutynin, which is an antimuscarinic medication. Their average age was 53, BMI of around 25, lowered their AHI 63%. So from an average AHI of 28.5 down to 7.5. Significant improvement just using these two medicines. And we've been using those medicines recently off-label just to see if there's, and we've had some modest success. Can we predict who's going to respond? Not yet. Other things, obviously weight loss, avoid alcohol close to bedtime, try to keep them off their back, especially if they have positional OSA. Most patients are still better off on their side if they're unable to use their CPAP. There are a lot of different positional treatments out there. None of them have been really well validated, but again, it's a way to try to help make sure patients don't go onto their back, especially if they're not being treated on their back. Here's a great example of positional OSA. You definitely want to see REM sleep on their side because that's going to be when they're most susceptible to obstructive events because of the paralysis that occurs during REM sleep. So if they're good on their side, right side and left side, this is someone you could be confident in. If they can do positional therapy, they're going to be probably pretty well protected. This person purely has obstructive apneas on their back. Again, the key is the protection during REM and non-REM. Here's a great example. They are better on their left side versus their back, but in REM, the apnea is pretty significant. So it's hard to encourage positional therapy in someone like this because their REM index is still very high. Their non-REM is essentially normal, but their REM is pretty bad. So it's not someone I would suggest using positional therapy in as a sole approach. Mandibular advancement devices, you can see there's a whole host of FDA-approved devices out there. You name it, many dentists, many other people have tried to make different devices out there, so they've not been well studied head to head. But most dentists use kind of a couple of devices out there. The original one that was always kind of prescribed in the late 80s, early 90s was the Thornton adjustable positioner, the TAP. We've kind of moved away from the TAP just because it locks the mouth together. Most patients, like CMS or Medicare patients, the Herbst appliance is what's approved by Medicare alone. So that's going to be one that Medicare will cover. So patients who are on Medicare that can't tolerate a CPAP or have mild sleep apnea, that CPAP may be too much for them, the Herbst appliance might be a good solution. And again, Medicare does cover that treatment. Somnomed Avant, that's another new one that has come out by this manufacturer. Again, there's a whole host of them out there. Each dentist kind of has their favorite one that they use or top three that they use depending on the oral anatomy. So I tend to leave it up to dentists to make the decision of which device they're going to use. Again, it's important to know that the American Academy of Sleep does recommend oral appliance as a standard of care, especially if it's mild sleep apnea. And someone with moderate sleep apnea that can't tolerate CPAP, it is a standard of care. It is important to understand if a patient is refusing CPAP therapy, and no matter what degree of sleep apnea they have, it is something to consider as a standard of care because it's some therapy versus no therapy. Again, we want someone who's a qualified dentist to be involved in the management of these patients, and then the sleep physician or the clinician to conduct follow-up testing, follow-up management to determine efficacy and make sure there's no other complications from using the oral appliance. So it's important to have a good sleep clinician and a qualified dentist to be involved in the care of these patients when working together. Other things that they recommend, but not strict guidelines, some x-rays to monitor any changes to their bite, definitely follow up with their dentist twice a year, and then maybe annually after that, just to monitor how well the device is working. These devices tend to last 5 years before they need to be replaced. Here's a great example of a patient with moderate to or so sleep apnea, actually severe sleep apnea. Their AHI was 44. They were woken up around 2 or 3 in the morning and put on a dental device. And you can see their AHI after a couple of turns with the device went down to 10.2. So a significant reduction in someone with an AHI of 44 at baseline, and then down to 10 with the oral appliance. And again, both in their supine and lateral position, there's some benefit with the dental device. Surgical therapies. So surgery, there's over 18 different surgeries for sleep apnea. So it's really hard to talk about all of them. We're not going to dive that deep into it, but it's important to understand where is this obstruction occurring. And sometimes you can tell just by looking at the patient, opening their mouth and looking at inside their airway, looking through their nasal passages. So it's important to understand where is the potential likelihood of obstruction. So we kind of divvy these up into 3 types of areas. Type 1, someone who's at the soft palate or behind the nasal passages. Type 2 is both the soft palate and behind the tongue. And then type 3 is pretty much behind the tongue. So it's important to kind of rate where are they in the airway passages in terms of likelihood of potential collapse. Here's, we obviously know tonsils play a big role, especially if they're in that +3 or +4 range, which is you can see on the right-hand side here, +4 tonsils on both sides are going to meet each other in the middle of their throat, block their entire back of their airway. So that's someone easy to say, hey, we should probably take your tonsils out, improve the amount of room you have to get airflow through. Here are some of the approaches that we sometimes think about. Obviously, the nose is important to think about. We want turbinate reductions, which is the tissue inside your nostril. If it's swollen, congested, sometimes Flonase and other sprays like that may not be effective. So they can reduce it, shave it down. They have a deviated septum, try to straighten that out if possible. So the nose is important. It may not treat the apnea directly, but help improve the treatments that might be offered for their apnea. When we go down the soft palate, we really moved away from uvulopalatopharyngoplasty, which is UPPP surgery that was done in the 80s and 90s quite frequently. Data shows that it doesn't work in everyone, maybe about 10% of patients it's successful in. So it's something we've kind of moved away from. There's still people getting these surgeries done, but I'm not sure if all of them really are going to benefit from it. There's a newer technique called a modified UPPP or a pharyngoplasty, which is more reconstructive. I think we have some slides show the picture of that. Pillar palatal implants was used for a while, but the data has shown not to be as effective. It was trying to stiffen the soft palate. There's some laser surgeries to the soft palate. Again, not always great data around this. And then there's Inspire. And you can see Inspire is listed twice on this surgical approaches. So if it's a tongue-based surgery, you can move the genioglossus, the tongue muscle forward. You can adjust the hyoid and advance that. People have radiated the tongue to kind of shrink it. Again, not great data around that. MMA or MMO surgery, maxillomandibular advancement, is probably the most widely recognized as a highly effective surgery, but has a high morbidity associated with it, some complications, requires a lot of effort to get them prepped for it. It's a major operation. And then there's Inspire again here. So you can see Inspire, which is hypoglossal nerve stimulation. It's a pacemaker that's implanted. We'll dive into this in a few slides here. When you stimulate the hypoglossal nerve, we actually see coupling of the soft palate to move forward and the tongue to move forward. So in terms of nasal reconstruction, again, we don't need to dive too far into this. We know septoplasty, turbinate reduction are kind of probably the mainstay of therapy in the nose. If there's sinus issues, again, definitely want to consider that as well. Again, UPPP has been done for many years. Again, the outcomes are good in the first year or two, but by year 5, a lot of the data show that these patients revert back to having apnea again. This is what I wanted to compare: a classic UPPP on the left. You can see they've removed the soft palate, removed the uvula. On the right, it's more of a curtain effect. They've moved things to the side to help kind of open the back of the throat without removing any tissue. So this is more reconstructive versus tissue loss or tissue removal. The recovery is better as well. So what are one of the tools to understand where in the airway is the blockage occurring? And what we've relied on most heavily in the last few years is something called the DISE, the drug-induced sleep endoscopy. And this uses what's called the VOTE classification. The velum, which is behind your soft palate, the oropharynx, which is right below that, the tongue base, which is right behind your tongue, and the epiglottis, which is right above your trachea and your food pipe, your esophagus. And the idea is, what's the collapse that's occurring here? So is it anterior, posterior? So is the front and the back of the throat closing? Is it lateral wall? Is the side walls coming together? Or is the whole thing coming together like a circle closing in? And what we know now is the people that have this circle closing in at the velum, at the soft palate or below the soft palate, if they close in like that, a lot of the surgeries don't work. Inspire doesn't work. So it's important to know, hey, how is this wall collapsing? If the whole thing's coming in, it requires a lot more work to keep that airway open versus if the front and back are closing in or if the sides are closing in. So it's important. This is why we rely on this a little bit more to understand where is the airway closing. This drug-induced endoscopy mimics their sleep, not exactly, but close, to watch their throat close and kind of understand where is this blockage coming from. Here's a great example of someone with anterior posterior collapse. So this is right behind your soft palate, right above your uvula, and the back wall and the front wall are coming together, kind of closing in. You can see it nicely there. And you can see the vibration. That's probably going to be their snoring noise you might hear. Here's someone on the right that has the whole thing closing in like a circle closing in. And this is one of the most challenging patients from a surgical standpoint to get that airway open from a surgery. So just removing some of the tissue alone is probably not going to help them completely. And this is why CPAP works great in this patient, because it doesn't really matter how that's closing. The whole thing's going to be open with that airflow. Okay. Inspire. And so the drug-induced endoscopy is one of the requirements to determine if someone's a good candidate for Inspire. There's a few other criteria we'll dive into. Here you can see the pacemaker, the battery is implanted right under your right collarbone. And then there's a lead that goes up to the nerve that controls your tongue, which is hypoglossal nerve right at the corner of your chin. And the sensor, the stimulator lead there is what's stimulating that nerve to move your tongue forward. What are the criteria? It's 18 and above. Their AHI has to be somewhere between 15, at least 15. The upper limit's a soft upper limit of 65. They have to have CPAP failure, and there's different terminology on what that means. And then the BMI ideally should be under 32. There's an upper limit of 35 sometimes. Some patients have been even higher than that. But the higher your BMI, the more likely that concentric, that circle closing in collapse is probably going to be happening. So this is why the BMI probably correlates well with the way your throat's collapsing. What's the pathway to get Inspire? We typically screen the patient. Are they a good fit, good candidate? Do they understand what it means to have a pacemaker? They go for the drug-induced endoscopy, where we work with an ENT surgeon at Ohio State and a few other centers around our city. They do the drug-induced endoscopy. If they're a good candidate based on that DICE, the Inspire procedure is scheduled a few weeks later. And then 4 weeks after the device is implanted, it's when it's turned on for the first time. So there's healing. We want everything to kind of calm down from an inflammation and surgery standpoint. And then the device is turned on. and then it's adjusted over time. So the device is titrated similar to CPAP. So a pressure of 5, there's a voltage setting on the Inspire. And then we can monitor their compliance through a cloud-based system to see, are they using it? How many hours a night? Are they pausing it? Which means they're waking up for whatever reason. So we can kind of see how they're doing with the therapy. This is the data that the FDA looked at to get approval. The STAR trial was the largest study looking at Inspire. And basically it was 22 centers, 126 patients, multi-center, and average AHI was 29 at baseline, and 3 years out showed an AHI of 6. Now they have 5-year, 7-year data now showing stable AHI. MMA surgery, major operation, typically, again, this is usually an oral maxillosurgeon that's going to essentially break the jaw. Now, there's some newer techniques that's less breaking as much as we used to have to do, but basically moving everything forward, moving the mandible and moving the maxilla or widening the maxilla to give your tongue more room in the airway. And very effective, but again, comes with some comorbidities. Again, it provides the maximal enlargement of the retrolingual airway. Some of the retropalatal, this is where it helps, similar to Inspire, moving the palate, moving the tongue forward will give you the most amount of airway space. So MMA does that more on a permanent basis, and therefore some people consider this as closest to a cure as possible, even though it might not be a full cure. Again, there's a phased approach to this therapy. It just depends, again, on the drug-induced endoscopy. What kind of airway are we dealing with here? Here's some great examples of seeing someone just visually and kind of determine, hey, they probably have a lower jaw here. You can see this is a class 2 airway where the lower jaw is set back. You can see his jaw is forward. So sometimes he's going to have more of an opening of his airway, and she may have less of an opening of her airway. So just, again, weight may not be as big of a role here. She can have a normal BMI and be severe OSA. He can have a high BMI and have minimal to no OSA. So it's important just to think about that, just because, again, the upper airway anatomy plays such a big role. Okay. Again, advantage of the MMA surgery or MMO surgery is the entire complex is being addressed. It's a one-time cost. And again, if you get to them early enough, it may help stave off other complications of untreated sleep apnea later in life. Again, there's minimal, there is some discomfort, pain. It does change their facial features. So it's important for them to be aware that they're going to look different after this surgery. And again, it's typically immediate in terms of the benefit on the airway. Here's some newer therapies I just want to touch base on before I finish up here. This was FDA approved earlier this year in 2021. Called Excite OSA. It's a daytime tongue stimulator. It's basically almost like a TENS unit or a stimulator to the tongue that you use 20 minutes a day for 6 weeks. And then to maintain the strength of the tongue, you need to do it once or twice a week after that as ongoing maintenance. And the idea here, it's been FDA approved for snoring. It's been FDA approved for mild sleep apnea. So someone with mild OSA or upper airway resistance or just snoring, they can do this 20 minutes a day and may not need anything at night. So it's a different concept in understanding how we might help these patients and may even avoid needing a therapy at night, which is a huge win for some of these patients. So a new treatment, it's not quite covered by medical insurance yet. And again, it's 2 months, 6 weeks to 8 weeks, and then maintenance therapy after that. So interesting, cool new therapy, recently FDA approved, something to be mindful, aware of as another solution for some of these patients. This is another therapy, again, recently FDA approved. You may have all been familiar with something called the WINKS, which was around about 10 or so years ago. The company folded, another company took on the technology and revamped it, and this is the new version of it called the iNap. This is a negative pressure device, so it creates a suction to kind of pull that tongue forward. So you have that mouthpiece here that sits in your mouth. It's not custom fit, just sits there. It's a soft, like silicone type material. And it's creating a negative pressure, creating a suction, the opposite of a CPAP, to kind of hug the tongue, pull it forward, pull the soft palate forward. Again, this is not for everyone. Currently, our success rate is somewhere around 30%. But again, patients who have no other options, this might be something that's out there for them that might be effective. This is for anyone with any degree of sleep apnea. So it can help someone with severe apnea to all the way to mild sleep apnea. This is another hypoglossal nerve stimulator that's potentially going to be on the market soon. It's available in Europe currently. This is a bilateral nerve stimulator. So there's two stimulators that are implanted in your hypoglossal nerve on the left and the right, where Inspire is only on the right. And the battery is external versus Inspire, which is the battery internal. And this is applied to the neck every night. You tape it to your neck, and it stimulates wirelessly those stimulators that are implanted and activates the tongue to move forward. Again, another future potential therapy. There's a few others in the hypoglossal nerve space that are potential coming out in the next few years. So just be mindful. Again, outside of Inspire, there might be other solutions out there that may work for some patients. So in summary, sleep apnea has serious long-term consequences you're all familiar with. We know it's the gold standard in terms of treatment of moderate to severe sleep apnea. Be skeptical of someone with CPAP failure, give the full effort. But again, still 40, 50, 60% of patients may not tolerate CPAP no matter how good you help them try. And it's important to understand that they need to have alternatives. And again, each patient might be different. What are their needs? What's their anatomy? What might they respond to? So it's important to kind of understand, hey, we need to be mindful of other solutions. Sometimes combining these solutions can be effective as well. Again, dental devices are clearly a standard of care, should be considered an option, just needs to be monitored closely, both with a sleep medicine specialist as well as a dentist who's trained in sleep as well. Again, it's important to know, hey, there's all these solutions out there. There's not a one size fits all model here. So it's important to educate patients, hey, if this is not working for you, you need to think there's other things that you can do that might help you. Here's kind of a model that's been mocked up in terms of trying to phenotype patients, kind of understand what might be the best approach. So depending on mild or moderate or severe, which path should we start with? And you can see with mild, the door is open now. There's more solutions out there. In moderate to severe, we should probably start with CPAP or BiPAP. Can they respond? Great. Let's go down that path. They're the easy green path, I would say, where they may not need anything further. If they're not doing well, we might need to understand what else is going on here. And this is where, are they overweight? Or is their BMI high? Is their BMI low? If their BMI is high, maybe we need to consider weight loss surgery, weight management, focus on that first. If their BMI is lower, let's go to a drug-induced endoscopy, kind of understand what's going on in their airway. Could a dental device work in that patient? Is MMA necessary? Is Inspire necessary? This is all kind of what we need to think about in that patient. Should we try Excite, get their severity down? Maybe then they can tolerate, or the oral appliance will improve them. So there's a lot of different ways to skin this cat. Can we try pharmacotherapy in this patient? So atomoxetine, oxybutynin might have a good response. So you can see there's a lot of different paths here we can take, and sometimes they cross paths. Sometimes we're going to get them to a better range, reduce their disease burden. But again, it's just important to understand there's more than one way to do this. And I would like to end there. Thank you.